So the next presenter will be Attila Szijártó, as I introduced him earlier, and he will speak about management of pancreatic fluid collections, guidance, and the daily practice. Attila, we look forward to your talk.
Thank you very much. Thank you for your kind invite, and I hope I will be able to talk you some important data and how can we work together. But so that's why I choose this topic, meaning management of pancreatic fluid collections, what is the guideline and how we do in the daily life. But before the profession, I would like to say some words about the center. What does it mean, the daily practice, what we do? Because right now, as you can see, this is the surgery, transplantation and gastroenterology unit, which is a quite new, big complex in the university. We call it a 3C, the complex, comprehensive, and complementary center. In the center, we've got more than 5,800 operations per year, including the transplantation and all other benign and malignant diseases. But the 40% of the diseases is a 3B progressive level, as we can call it in Hungary, and more than 50% of these cases in oncological cases. And the surgery and the gastroenterology work together for many years, and right now this is a new way. And so our 85% of our cases, it's about gastroenterological and surgical cases. So this is we call it Hungarian stake, but this is the surgery, transplantation, and gastroenterology unit. So it's more than 100 years experience we've got. That's why I put some data. There is a quite old story. Unfortunately, it's quite an actual story because it was written in the First World War when there was a patient with a pancreatic cyst. So that's why it's anyhow related to my presentation. Which was transferred to the first department at the time. It's called the first department of University of Surgery, and there was Professor Dollinger who handled it at the time. So this is the place where we do the pancreatic diseases and pancreatic surgery more than 100 years, as you can see. Yearly, we've got around 150 resection per year in the Ülői Street, and right now together with Parasutsa, as you can see, this is the old transplantation clinic. The number is around 200 per year. So there's a lot of research and a lot of educational fields which we do. This is some name, there is some name from our ancestors, and you know, these guys written a lot of things about pancreatic surgery at that time. And we are very proud for the time when we introduced the first US in Hungary, and several years ago we established the HPB Surgical Research Center, which is a network where we work together with the professions who are involved in, interested in hepatopancreatic biliary surgery and gastroenterology. That's why, as you can see, a year ago, more than a year ago, we established a unique gastroenterological department in the Semmelweis University, which is work together with surgery in the big, huge complex. More than 25 years, we've got very good gastroenterologists who lives with us together. But right, this is an official way. And the last year, this is a number which we've done in the field of gastroenterology related to the pancreatic diseases. And we've got much more in other diseases, which is not so important. Right now, there are three keywords. So we respect for our ancestors, pride for the value, and humility for the professions. So speaks about some words about the profession. So I would like to speak about the pancreatic fluid collection and the management. As you can see, the acute pancreatitis may complicated and development some fluid, and this is a major cause of morbidity during the pancreatic diseases at the time, and it is classified in several ways. This is the revised Atlanta classification, as you can see. This is the intestinal edematous pancreatitis and necrotizing pancreatitis, and the time is a key factor how can be put into groups the pancreatic juice or fluid collections. We could do pseudocyst, the necrotic collection of wall of necrosis. Some samples, for example, this is the acute pancreatic fluid collections, which comes with the intestinal edematous pancreatitis at the first full week, and there's no any features of pseudocyst. This is a peripancreatic pseudocyst, which is an encapsulated collection around the pancreas. More than 4 weeks we can detect it, and we're waiting for this stage several times, but it comes with the moderate pancreatitis. This is the acute necrotizing collection. We have no wall, and this is there is both fluid and necrosis around the pancreas. And several cases we find the patient in this stage when comes to the surgery. And there's a wall of necrosis, as you can see, this encapsulated necrosis after 4 weeks. How can we manage it? What is the main issues? The main issues is when, how, and who can do anything with it. So if we look back to the classification, then we could say right now we are not very active in the acute peripancreatic fluid collection at the first time, which is less than 4 weeks. We are really interested in the pancreatic pseudocyst and the wall of necrosis, and some of the cases we have to do something with the acute necrotic collection. The time limit or the threshold is 4 weeks, which is a critical time in the patient's life, and maybe the outcome will be involved by this time as well. So what is the indication for any type of intervention if these stages comes earlier, the 4 weeks? One of them is an infected pseudocyst or infected fluid collection. We've got high suspicions for infection, or we've got a non-infection, or there are some symptoms which meant that we have a sterile collection, but we have to do something earlier than 4 weeks. So the time, so we have to waiting for the encapsulation or walling of this is critical for the successful therapy. This is, as I mentioned, is 4 weeks after initial presentation, and the mortality rate is more than 28 days, because there's a big difference between if we do something earlier than 4 weeks, it's 10%, it's after it's 5%. And the median number of days from acute pancreatitis, the 13th intervention, was around 50 days in a US center. So this is the history, what was in the past and what is in the present. I will tell some words about the open surgery era in the 40, 30 years ago. And right now there's a minimal invasive method, and we have to do the multidisciplinary treatment, the step-up approach. So around the 1990s, there was a very active period in surgery when all pancreatic or acute pancreatic disease patient would underwent operation, but the mortality rate was very high. So that's why there was a big change around it. And there was just a lavage and the blunt removal of necrotic tissue procedure around the 1990s. And the mortality was high, but a bit lower than was the previous age. And there was a very high risk of long-term pancreatic fistula and insufficiency after this procedure. So that's why we have to change something in surgery as well. That comes the minimal invasive method, the percutaneous catheter drainage, endoscopic, and minimal invasive surgery. And that is the point when I have to emphasize the importance of the daily routine, because there's a lot of things in the guidelines, but I think we're not able to follow all the details of the guidelines in the daily routine, because what is the optimal intervention strategy? In the guidelines said the imaging guided percutaneous catheter drainage could be the first, but the endoscopic and transluminal drainage could be the second one, followed if it's necessary, the endoscopic is or surgery, necrosectomy is needed. So how about the percutaneous way, US and CT guided catheter drainage? Some previous guideline try to emphasize the importance of the percutaneous drainage, but in our daily practice we are not so keen on this technique because late complication, meaning pancreatic fistula, is very high after this type of intervention. So that's why we like to choose the endoscopic one, which could be transmural or transcapillary or EU as guided endoscopic treatment, which could be a direct endoscopic necrosectomy or Nowadays, there's a lumen-opposing metallic stent, the lumps, which we used, and we've got more than 25, 30 cases in the last few years. So this is one very nice picture from István Fritz. Maybe he will show this one again, I don't know. When we put a hot axial stent, it's a lumen-opposing stent to the pancreatic juice after 6 weeks of the collection. And this is the ultrasound picture when you can see the insertion of the catheter. And this is the X-ray guided fluoroscopy when you can see the dival of the stent here and opening the neck, and the other opening will be seen here later on, right now. And this is the way how can we go back weekly and make a drainage or make a necrosectomy through this dival stent and put a leaf back a long nasocatheter drain to make a lavage, as we performed it several decades ago in surgery. There was 2 big trials, the Gepard trial and Penguin trial, which is about endoscopic and transgastric treatment versus surgical necrosectomy. There are some cases where we are not able to do endoscopic necrosectomy. For example, there's a significant reservoir necrosis or a persistent sepsis or a huge collection, which is not achievable for the endoscope, or we can count some complication, for example, pseudaneurysm or hemorrhage. Here is one case when we have hemorrhage after the stent implantation at the time, and we do intervention with featured with some coils, which we put to the leakage, and that was the final solution for the patient. And there's one issue when the malignancy can be not ruled out, that this is the way for surgery. So this is the other predictors for surgery. It speaks about the Apache score, a renal failure index, or there is infected bacteria isolated juice in the pancreas. And that's why when we have changed our method from endoscopic to surgery. And this is a surgical approach, and this is the way how we can handle the surgical cases. This is a sinus tract endoscopy. Is not so fabulous because there is a quite old instrument which is needed for that. This is the way, because we've got a we've got a collection. We have to put a drain at first, and after there's a flexible endoscope. This is an operating nephroscope, which we put through the way, like a Seldinger method, and after there's an irrigation, and this is the way how we can remove the juice from the retroperitoneal space. This is not a common practice in Hungary. The other one is much better, and we got some cases. It's a videoscopic assisted retroperitoneal debridement when we've got a wall of necrosis somewhere here, and after we have to go into the retroperitoneal space with laparoscope, and we can explore this region and remove the necrotic tissue, and there's a suction and irrigation at the place, and maybe at that time we can close it directly, or we find the pancreatic fistula. And this is the endoscopic assisted retroperitoneal debridement. This is the VARD, which is widely used in Europe. There was some multi-center prospective single arm trial in this case, and it said that this is a safe method with low morbidity and mortality compared to the open surgery. And now in the laparoscopic era, we can solve everything with laparoscope as well. So that's why we've got three several methods how we can remove the juice from the pancreas: retroperitoscopic or transgastric way. The transgastric way is anyhow referred about or very similar to the previous operations, which we performed transgastric way for pseudocyst. This is the way how we can go through the first wall of the stomach and after find the closest point between the necrotic juice and the back wall of the stomach and make an opening, and after we can remove the debris from the area. And we are waiting for the Waldorf necrosis in this session as well. So this is the laparoscopic necrosectomy, which is a suitable method, and this study showed that laparoscopic surgery is safe with low morbidity and mortality compared to the open surgery. And there is another very important information for us, because in laparoscopic way we can manage the pseudocyst as well, like open surgery. And right now the robotic surgery is here in Hungary, and maybe in some other university we'll be able to introduce it in a few months. But there are some technical advantages. How can we handle it, or how can we do the previous procedure, but the outcome or the solution is more or less the same as we can perform by laparoscope. So this is the way of the intervention, how we have to build up our step-up approach. So the guidelines said we should start it with percutaneous drainage, but we are not so keen on that. We should start with endoscopic drainage, and after, if there's no any solution for that, we have to change to surgery. It could be an open way or video-assisted retroperitoneal debridement, and maybe in the near future we'll can cure it by robotic surgery as well. This is the same trial. This is a trial which tried to emphasize the importance of this step-up approach, and it said that the endoscopic step-up approach was not superior to the surgical step-up approach in reducing mere complication or death. The rate of pancreatic fistula and length of hospital stay were lower in the endoscopic group, which is very important for the late outcome for us. And this is the same approach, and this is the same way how we have to build up the treatment. And this is 3 keywords from the 3D approach: delayed, drain, and debride. So this is the way, and this is that keywords which we have to keep in our mind during the whole process. Thank you very much for your attention.
Thank you very much for this very comprehensive presentation. And my question would be concerning the infected pseudocysts and also mode of necrosis as well, because now it's also in international, it's discussed. I know it's a New England trial came out recently that whether in these cases, whether the interventional approach should be in front of antibiotics or not, or when to operate these patients, or when to make like even endoscopic intervention. So should we intervene all infected ones, or just using antibiotics wait and see and try to delay the surgical interference as we can?
So it depends on patient. So at the first time we have to wait as long as we can, but if the septic complication can be, we're not able to cure it, that the first time we started with endoscopic procedure, anyhow to drainage to the juice into the stomach, for example. Some of the cases that quite interesting complication, because the several toxins which goes directly into intestinal tract can cause a very intensive and aggressive reaction. But if there's no any solution, several cases we have to do surgery.
Congratulations, Attila. I wish to ask your own data that how much of your persons with peripancreatic fluid collection separated pseudocyst and wall of pancreatic necrosis really require therapy. So how much of them needs a surgical therapy?
Unfortunately, right now we've got much more acute pancreatitis cases as it was 10 years ago. Maybe the centralization comes with it, and that's why the percentage of the patient who underwent surgery is around 15%.
Could you separate it pseudocyst patients?
No, it's an acute cases. The pseudocyst operation is handled by endoscopic way. It's just there's a few cases when we have to do any surgery for pseudocysts. So several years
That's
ago,
what I wanted to hear.
Yes.
0%.
No, zero. Several decades around it because we have a lot of decompression operation because pseudocysts, but right now we've got yearly 5 or 10 cases only which we have to do that. But Ákos maybe have much more data about it.
Because I believe that the first line treatment for pseudocysts is the
Sure.
Okay, that's
sure. Yes. Sure.
Okay.
Any other questions? No, then thank you very much, Attila.